So you're telling me that the stragglers aren't really worth waiting for? Is that what you're saying, Mrs. Haig?
I'm just statistically a lot better off than I was a minute ago. I went out and yelled in the hallways, if you want to know the truth, and said, get in here.
Okay, sounds good. So when we're talking about age, we're talking about the very young and the very old. And when we're talking about infants, they have an increased metabolic rate, which means they use fluid and electrolytes, they use them up more aggressively, as well as the nutrients that they consume in order to grow more tissue at a higher rate than what adults typically do. Their kidneys are also immature, and as a result, they don't conserve fluid and electrolytes as effectively as an adult does, which means they are more prone to losing too much too quickly. Okay? When we're talking about the elderly, they often have a decreased perception of their thirst. So they don't always remember to get a drink when their body might very likely need one. And many times they have chronic diseases that affect their kidneys or their heart or both, and as a result, they don't eliminate fluid effectively and they don't conserve fluid effectively. Most often they don't eliminate it. That's the more probable one for most of them. So remember we talked about in Mrs. Martinez's lecture, she talked about how important urinary output was, and that the normal amount for an adult is 50 to 70 mils per hour, but that the minimum was 30 mils per hour. Well, when you have a weak heart or damaged kidneys, many times those numbers look much smaller, and so over time, it's very easy for those people to get into a fluid overload situation or a hypervolemic situation. And so they often develop peripheral edema, pulmonary edema, or even fluid in their abdomen that we call ascites. Okay? Gender and body size. Just like Mrs. Haig said when you learned about the rule of 5 and rule of 6s, I'm sorry, this is not fair for you women, but it's just the way it is. Fat cells contain little water. Lean tissue has very high water content. So what that means is typically the more muscle mass a person has, the more water content in their body. The more adipose tissue they have, the less water content. And unfortunately, a lot of women have more adipose tissue and as a result have less percentage of body fluid than a man who might be their same height. Okay? So when we're looking at an obese individual, their overall fluid volume is maybe 30 to 40% of their overall weight. And remember I said a while ago that for a non-obese individual, it's closer to 60%. So you can see how an overweight individual could very easily get into a fluid electrolyte problem much faster because they have less reserves to work with than someone who is not. Environmental temperature. So an increase in environmental temperature leads to more sweating, and with that sweating, we lose both water and electrolytes, and as a result, that person can become volume depleted very quickly. It's more pronounced if they're very engaged in strenuous activities, so physical labor, sports, running, marathon type thing would add to that. Diet. So remember, everything that we need to maintain our fluid electrolyte status comes from our diet. So it is our only source of both fluid and electrolytes. And unfortunately, we would like to think that everyone does a good job at meeting this need, but many times people don't. Many times there are certain things they avoid because they don't like them, or they don't drink or eat enough things that contain them, so they have inadequate intake of certain electrolytes, or they have an excess amount. How many people like French fries with their sodium? Okay. Stress. Increased metabolism. Okay, remember stress releases glucose into your bloodstream, and those catecholamines we call adrenaline and norepinephrine. And those catecholamines stimulate increased metabolic activity. And so they're going to generate more heat, and they're going to influence the fluid electrolyte status in that respect. But they also affect ADH secretion, because our body knows that during that fight or flight response that injury could occur, and injury means potentially a loss of blood. And blood, having both fluid and electrolytes, could be a significant loss for that body. So in order to prepare for that possible occurrence, our body secretes additional ADH when we feel anxious, and as a result, our urine output decreases, and we conserve more to increase our blood volume, so that even if we do take an injury, hopefully we will have enough blood volume to survive. Okay? Alcohol. Alcohol has numerous effects. It affects our electrolyte balance in multiple different ways, but it's also a mild diuretic. Okay, and I say mild, mild in respect to a ratio. In other words, if you only took that 1 beer or 2 beers for a man that Mrs. Haig talked about, then it's probably not going to have much diuretic effect. But most people who drink don't drink like that. And so as a result, it's only a mild diuretic if you drink in a mild fashion. So the more you drink, the more you eliminate your electrolytes and fluids. And as a result, you can deplete those 3 electrolytes specifically are prone to loss as a result. And when you don't take adequate nutrition in, your body begins to use adipose tissue, and we'll talk about this in the diabetic lecture, but your body begins to use adipose tissue, and you begin to develop a lot of ketones in your blood. And those ketones lead to a metabolic acidosis. And that metabolic acidosis then begins to disrupt all the other parts, other components, if you will, of your fluid electrolyte status. Okay, so a lot of people who struggle with alcohol addiction, they drink their diet, they don't eat it. Okay, many of them spend most of their nutritional money on alcohol consumption rather than food. Okay. All right.
So in that case, if
Question?
what you're saying as
Hold on. Say it real loud.
so with what you're saying, like if somebody was an alcoholic and say they didn't have any additional health problems, what you'd see is little bitty skinny people with
Yes. Yes.
alcoholism.
Someone who is addicted to alcohol, has alcohol dependence, and has switched to where they're so psychologically and physically consumed with their next drink, they will often not eat adequately, and over time they will become thin and emaciated with a big pot belly. And that big pot belly comes from the lack of protein in their blood and the damages to their liver. And we could talk about that in great length, but just in a simplified version, our liver is what takes the protein that we eat and makes it usable protein for our blood. So albumin is the precursor of all the other tissues that your body builds from protein. And so if your liver can't start that process, then over time, your oncotic pressure drops and the fluid doesn't have a way to stay in the vascular space. So the fluid leaks out, peripheral tissues, especially the abdomen, and they get ascites. And so they have a big cushy belly that's full of water, and it's a result of protein, like is on the screen right here. The liver damage that has occurred from their alcohol use makes it where they cannot form proteins effectively. Okay. So many times they have skinny little arms, skinny little legs, because their body is breaking down those protein sources, but it's not able to use the new ones very well at all.
So it would be in essence easier to, as long as somebody didn't have a whole bunch of other comorbidities, that you could identify an alcohol problem based on that as one of the observations.
That is some of the observations, but there are some other things you'd have to rule out along with that. Okay, so that's not the only signs or symptoms. Yeah. Okay, so we already said that the heart and the kidneys have to work together. So somebody who has congestive heart failure, or the newer term is just heart failure without the C in there. Somebody who has heart failure has a compromised cardiac output. As a result, they don't perfuse or they don't force blood through the kidneys effectively to filter well. And so gradually over time, what ends up happening is fluid accumulates in the vascular space and then it's forced out into that interstitial space through hydrostatic pressure. Okay, so somebody with heart failure typically has both pulmonary edema and peripheral edema, depending on which side of the heart fails first. Somebody who has kidney problems, kidney disease occurs in what we call stages. And so there are stages where a person does not concentrate their urine. Basically, everything that's filtered goes out into the urine. And so those people in that stage of kidney disease make a lot of urine, but it's very pale and transparent. And as a result, they get volume depleted. They are people that literally have to drink water like a racehorse just to keep up with what they're peeing out. Okay? They can't fix the problem. Another stage of kidney disease is the exact opposite, where the kidneys no longer filter effectively and fluid accumulates in the vascular space, leading again to that same thing that heart failure does, peripheral and pulmonary edema, hypervolemia. Okay? And then I mentioned the liver damage already. So it's not just alcohol that damages our liver, hepatitis does as well. And there are also certain drugs that damage our liver, such as the acetylcholine.
Mr. Baird?
Yes.
Are you hearing student mics perhaps? There's a lot of background.
Oh, yes. I'm sorry. When my student asked the question, I opened it up. Thank you for letting me know. Is that better?
Yes, much better. Much better.
Okay, thank you for drawing that to my attention. Okay, so there are other things that can damage the liver, but if any of those three organs are damaged, there is a high potential for that person to have a fluid and or electrolyte problem. So how do we identify the specifics that are going on for that person? Well, remember we said that we measure electrolytes only in one fluid compartment. Stillwater, what was that fluid compartment? The intravascular. Okay, so that's part of the extracellular component. So when we're looking at these lab results, we're not looking at the amount of electrolytes in the tissue, we're looking at the amount of electrolytes in the bloodstream. So we can measure each of those electrolytes that I mentioned earlier. All of those, if you look them up in your Mosby's, has a normal range for venous blood. But the one I want you to focus on for this fall is the potassium level. I want you to know that number and know it well. In Adult 2, your last semester with us, you will focus on the calcium and magnesium and those other electrolytes. So you'll get another electrolyte lecture, but it'll be on those other electrolytes, okay? Hematocrit. Hematocrit is, we take a tube of blood and we run it through a centrifuge and spin it down. So all the heavy stuff, all the solutes in the blood go to the end of the tube, and then on the top of the blood is the amount of liquid or plasma in the blood. So hematocrit is the volume of cells or solids in that blood in relationship to the volume of plasma. So when a person has too little fluid in the vascular space, or they're dehydrated, or we're going to use the word hypovolemic, then their hematocrit will be higher than normal. When they are overhydrated, so maybe they've received too much IV fluids, maybe somebody ran into gravity and they didn't keep an eye on them, or maybe they have one of those kidney issues or cardiovascular issues, and so they're not urinating effectively and they're overhydrated, that hematocrit will drop. Okay, so it'll be less than normal. Serum osmolality, it's measuring those solutes, specifically those electrolytes. It's a formula for most hospitals that they calculate the osmolality rather than truly measure it based on several of those electrolytes in an algorithm. So again, The osmolality will be high if the patient is fluid volume deficient or hypovolemic, and it will be low with overhydration. Now, urine-specific gravity, remember what I just said about kidney disease, because notice how I don't use the same terms on those sentences. I don't say that urine-specific gravity will be high when the person is dehydrated and low when they are overhydrated, because it's not just hydration that we're looking at when we're talking about specific gravity. We're talking about the kidney's ability to concentrate urine. In a healthy set of kidneys, the urine will be more concentrated when we are dehydrated and more dilute when we are overhydrated. But it's only during the time that there is a healthy set of kidneys. So you have to look at this in the context of whether that person has kidney disease. Otherwise, it doesn't have the same meaning as the two previous ones. For each of these tests, what we need to know as nurses is MPO is not required. We can draw these people's blood at any time of day they come into our facilities to evaluate their fluid status and their electrolyte status. And we are, as nurses, expected to read those results and report critical values as soon as we observe them so that the primary care provider can respond to them. Because remember, even slight differences in fluid status or slight differences in electrolyte levels can be very significantly dangerous for that client. And then our goal as nursing is we're going to restore either their fluid level or their electrolyte level or both to normal just as quickly as we are able. And so we're going to focus on that when we talk about these nursing problems that we're about to look at. So with each of the lectures I present to you, and those that Mrs. Martinez presented and those that Mrs. Haig, that are what we call clinical lectures, we try to help you think like a nurse by teaching you the 3 to 5 most common nursing problems that those people will have with that body system. So without looking at the other electrolytes, just potassium and just fluid today, we're going to focus on those 4 problems. So those 4 problems, very specifically, are too little volume in the blood and too much, too little potassium and too much. Okay? So we're going to look at what leads to these problems. We're going to look at how we identify them as far as signs and symptoms, and then what do we do with them as nurses. So basically, we're going to take the nursing process and break it down for each of these nursing problems, just like all 3 of us have done with these clinical lectures. Okay, so let's start with the first one. Oh, I'm sorry, I forgot the slide was in there. So when we're talking about nursing care for a fluid electrolyte problem, doesn't matter which of those 4 problems the patient has, these are the 4 things, these 3 actions or nursing interventions are relevant in every case, okay? Kind of like the 3 actions we said when a patient comes in and has a cardiovascular problem. We had 3 interventions that were universally applied. The same is true when they have a fluid electrolyte problem, okay? So know them, understand them, not just memorize them, but understand them, okay? All right, so the first one we want to look at is hypovolemia. Very simply, it simply means there's just not enough of what we need in that vascular space. So many times when we talk about hypovolemia, we're talking about both electrolytes and water being inadequate. There are some conditions where it might just be an electrolyte problem, or there are a few conditions where it's primarily a water problem. But for our conversation today, we're going to consider it's a problem with both. Makes it easier to learn in the beginning. So some things that cause that. So these are etiologies. Remember, we use etiologies as a word to identify sources of patients' problems. So etiologies are risk factors that are demonstrated by that patient. In other words, each of these you could also call a risk factor, but if the patient you're assessing has this problem, then it's very likely the cause of their patient's hypovolemia. So a risk factor becomes an etiology if your patient has it. So vomiting, diarrhea, Remember, everything comes from the outside of our body, but it has to be absorbed through our GI tract. So if we're vomiting, we don't have time for it to get to the small intestine, which is where absorption occurs. If it passes too quickly through the intestine, and then again, we don't have enough time to get all of the good stuff out before it's lost out the back door. Dementia patients, part of the course of their cognitive impairment, they reach a point where they no longer recognize body sensations. They no longer recognize when they're hungry, when they're thirsty, when they're sleepy. Many times they don't even recognize pain. So they may have an injury and not even be aware of it. Okay, so the way their cognition has changed makes it where they're very prone to become hypovolemic, because they simply don't eat and drink enough unless we prompt them to, or unless we provide them that opportunity. Heat exhaustion, we're going to talk about that in the temperature lecture, but heat exhaustion is simply where environmental temperature and a patient's activity exceeds their ability to cool themselves off. So they basically use up all their surplus water and electrolytes through perspiration, and they just get volume depleted. And the symptoms occur as a result of that. There are certain medications. What's a medication class that we've already talked about, Tonkwall, that can lead to hypovolemia?
Diuretics.
Very good. Diuretics could. Are there any others? Does anybody know of anything else on any of the three campuses?
Laxatives?
Very good. Very good. So laxatives or even suppositories or, okay, so somebody preparing for a colonoscopy, we can significantly disrupt their fluid electrolyte status, and especially if they're an elderly person who has very little reserve. Okay? Does anybody think of another et cetera here that could lead to hypovolemia? Think really hard. You see a lot of it on primetime television.
Bleeding out?
Very good. Hemorrhage, injury. Very good. Okay? So what are we going to see? Well, these are some examples of things we would see in that individual. So their skin might be overly dry, may or may not be flaky, but when we test their skin turgor, when we pinch their skin up on their sternum, it's going to tint. And remember, tint means it stays pinched up, and we time it. Skin should be elastic when it's well hydrated. The cells should be well lubricated with that interstitial fluid, and it should bounce right back. When it's not, what has happened is that low volume of fluid in the vascular space has literally drawn fluid from that interstitial space to replace it. And if it can't keep up with the demand, then the patient has that decreased skin turgor. They have dry mucous membranes. If we measure their weight and have a baseline to measure it against, they'll have a weight loss change. It might be that they report they haven't felt like drinking. Or if they were talking about their family member, my mom or my dad who has dementia, I can't get them to drink more than a half a glass of water at every meal. Okay, so they report that they're not taking in fluids. Or they might have some of those abnormal losses like those that we talked about up above there. And sometimes even pleural fluid is missing. And so when we listen to their breath sounds, we hear a friction rub. Okay, there's a grating sound as the tissues are rubbing against each other. And then, where am I at? Am I at Stillwater now? What's a positive tilt test? They said real loud. I don't know if they caught you.
When your pulse or blood pressure increases or decreases on your main positions.
Okay, so which does what?
Blood pressure decreases,
Blood
heart rate
pressure.
increases.
Very good. So when we change from what position to what position, does our blood pressure decrease and our pulse increase?
Laying down the sitting position.
Very good. So when we do a tilt test, we test them in 3 positions. Some textbooks will say you can use 2 and still get the same results. But basically, we're going to lie them down for about 10 minutes. So allowing their vital signs to stabilize. We're going to check their pulse and blood pressure. Then we're going to have them sit, and we're going to immediately check their pulse and blood pressure again. Then we're going to have them stand, and we're going to check their pulse and blood pressure a 3rd time. If the differences between those positions indicate a 20 millimeter drop in mercury for the systolic blood pressure, or a 10 millimeter drop in mercury for the diastolic blood pressure, or if they have a increase of pulse by 15 to 30 beats per minute, or if the patient reports signs of hypoperfusion, so dizziness, I'm seeing stars, the room's getting dark, or if they actually have syncope, all of those are what we would call a positive tilt test. And if the patient is not on an antihypertensive medicine, and those things occur, it is almost always a fluid problem, hypovolemic problem. They are volume depleted. Okay? Questions about that?
Can you repeat the systolic?
So the criteria is if the systolic drops 20 millimeters or more, if the diastolic drops 10 millimeters or more, if the pulse, if you add those 2 numbers together, 10 to 20, or 5 to, if you add those 2 together, divide it in half, that's your pulse. So 15 to 30, okay? If it increases 15 to 30 beats a minute, that's a positive. If the patient has symptoms, so if they see stars, they feel dizzy or lightheaded, if they say the room is growing dark, or if they actually have syncope, actually faint, then that's a positive test. So what do we do as far as nursing? As far as nurses and healthcare team? Well, oh, well, thank you. I need to keep my hand up there or something. I'm not sure how to make myself remember to look down with that.
If you figure it out, let me know.
Well, I only got 2 more days to figure it out, right? Next Tuesday and one other one, so. All right, so our primary action is we're going to try fluid intake. Okay, so that our primary and our preferred route is the oral route. For those clients who are able to do so, that's the way we want to do that. So we want to help them, work with them to set realistic fluid goals for both a 24-hour time frame as well as a short-term goal. So what that means is we said that we need approximately 2.5 liters of fluid on a given day. Okay? So that equivalates out to about a little over 100 mils an hour if a person drank every hour for 24 hours. Well, we know that most people don't. We want them to sleep. So we have to shift those nighttime hours to daytime hours. So about 150 mils every hour or so while they're awake will get them to their goal. So a short-term goal would be about 150. Our 24-hour goal would be between 2 and 3 liters. So anywhere between 2,000 and 3,000 would be adequate for most individuals. The exception to this rule, however, is those people who have cardiac or renal problems. If we gave them that much fluid, even a single 24 hours, we might kill them, okay? Because they may not be able to recover from that much fluid in a short period of time. So keep in mind those individuals, we use a little bit different standard, a different process. Don't worry about that right now, just be aware that it looks different, okay? Make sure your patient knows, make sure your client understands what the rationale is for making them drink, because remember, if their primary reason for getting here is they don't drink enough, it might be hard to get them to drink that much, okay? So help them to understand so they'll want to participate. Try to identify the things they like, and when possible, as long as it's not something like the alcohol or a caffeine-based, which is our next line there, both of those having a diuretic effect, as long as it's not one of those, then try to make it available to them if it's accommodating to their diet. So if they love fruit juice, if they like Gatorade. Even non-caffeinated soda can be useful when we're just trying to rehydrate someone. And milk or dairy products, because of the electrolytes, is even better. Encourage foods that also have a high liquid component. And so I've given you some examples. You guys can probably come up with some others as well. Whatever you serve them at the appropriate temperature. So if it's something that should be warm, serve it warm. If it's something that should be cold or iced, serve it cold and iced. Whatever is most palatable for the individual will help promote that intake. And then those individuals who have swallowing difficulties or have mobility issues, so that maybe they have had a stroke, then that they might require some assistive devices. Make sure we make those available so that the patient can easily consume what they need without aspiration. And then if they are of a different culture or have a different belief system than the dominant one, then we need to ask those questions. Is there anything that you would like us to avoid when we bring you things to eat or to drink? And then honor those requests where possible. There are certain times of the year that certain faiths, certain religions avoid certain substances. And so again, if we can honor that, it conveys respect for that client. Questions about hypovolemia? Anybody? All right. So, besides all of this pertains to oral fluid intake. So we're going to talk here in a moment about some alternative routes. But before we get there, what are two alternative routes to increasing that person's fluid intake? IV and NG or very good. We're going to talk about one of those here in just a little bit. Our next problem on that list is hypervolemia, which simply means that there's too much water or too much electrolytes or both in the vascular space. In other words, they're engorged, if you will, because that space is a closed space. So we already mentioned those first two. Renal failure or heart failure can lead to hypervolemia. I mentioned excessive intake in the contents of the IV being too fast. So a runaway IV is a good example of somebody getting hypervolemia, and that happens most often with little guys. So pediatric patients, we have some safety approaches that minimize some of that risk. As far as adults, we try to minimize hanging things by gravity unless they are hypovolemic and need a rapid fluid infusion. Blood transfusion can lead to hypervolemia. Let's see, where are we at? Are we at maybe Tonkwell? Tonkwell, why would a blood transfusion lead to hypervolemia?
Because you're increasing the blood the person already has, so their fluid,